So we've replaced the hum of the jet ski, the sound of the bellbird on D'Urville for the hum of Ponsonby traffic. So what we've done today is we're coming to see Dr. Mark Gray, and people turned up and had the mole map camera look at their lesions on the skin, and what we're doing is those people that were worried about a mole, a couple of them I was worried about. So we've sent those pictures to Dr. Mark Gray. Now Mark's one of New Zealand's top dermatologists in my view. He founded Mole Map. He's also a skin surgeon. So I'm going to show him the lesions we've picked up, see if there's any he's worried about, the patients have been worried about it, and see if we need to do something about it. Okay Mark, well here's the thing I was worried about when I looked at it with the naked eye, and when you look at it under the Mole Map camera it looks even worse.
Yeah.
What do you think this is and what do we need to do about it?
This is a fairly typical example of what's called non-melanoma skin cancer. It's
Yeah.
not a melanoma, you know, everybody thinks skin cancer is all about melanoma, but
Exactly.
much more common to have non-melanoma skin cancer. So this is an example of that. This is on her knee, and it just kind of looks like a non-specific red patch. You might think, oh, that's just a bit of dermatitis, or it's a fungal infection, or psoriasis or something.
Yeah.
But it's not, you know, it's a little sneaky skin cancer, that. And so for this, if you don't identify that, well, it's probably not going to kill you, but it'll become a real mess. It'll form a nodule, it'll go right through the bone eventually, so you've really got to treat it seriously.
So your advice in this patient is it needs surgery?
That's the ideal scenario, because then you know you're going to go in there once, you can take care of it, you're going to cure it, and have a happy patient.
So, Dr. Tom, hey listen, I'm with Dr. Mark Gray, and as I said to you when I saw it, I'm a little bit worried that this may be a skin cancer. It's not a melanoma, it's not one that's probably going to kill you, but it's one that can erode into the bone, it's getting bigger, it's about 1.5 centimetres, so the decision is we need to cut it out. Okay, you happy with that? Okay, look, you can think about this. I'm not asking you to make a decision right on the phone now, but I just need to sort of plan it. Your options are that I can come down and do it. I mean, I used to be a surgical registrar and run biopsy clinics, so I've done, probably 1,000 of these things. You can come to Auckland if you want to, a few days up here, or you don't have medical insurance, do you? No, okay. Well, you can go to your GP, and we're going to send them the images anyway, and you can go on the waiting list, or you could go privately in Nelson and get someone else to cut it out. Okay, so you're thinking you might want me to come down and do it. No, there's no charge for it. I'm not going to charge for it. I believe in finishing what we started, and it's part of an education program. But I might charge you a couple of nights accommodation, probably stay with you, and you got to show me where the powers are. You've got to sign consent, and we've got to go through the whole process and make sure you're happy with it. And when I say it's not a commitment yet, we're just trying to plan it and see what we need to do and what we need to bring. And even at the last minute, if you get scared at the sight of that scalpel, you can back out and get it done somewhere else. But we really recommend that it needs to be cut out no matter what we do. Now it's time to head to D'Urville Island on Air New Zealand. Do a bit of surgery. Just need a bit of a sleep and a bit of a swim, and we'll be right. Looking forward to it. So talk us through French Pass.
Well, French Pass is just a narrow gap with a big reef going across it, and there's just a lot of water squeezing up and shallowing up as well, which is why we've got a lot of tide and eddies and whirlpools and things. It's just pushing through a narrow gap.
Thanks for the lift, Craig. So look, it's fabulous being here on D'Urville and driving. Well, we've stopped at the moment, otherwise we'll go off the edge because it's kind of steep. But the first thing you noticed about being on the island is the amount of bird song. Now, as a forest ranger before I was a doctor, so one of my jobs was identifying birds. So we can hear some bellbirds, some tuis, quite a few fantails. I heard a yellowhead before. So yeah, it's deafening, the sound of native birds. So a couple of questions is, what did you think it was and why did you let it get so big?
Well, I thought it was just a scar.
Yeah.
I thought it was a scar that just didn't want to go away.
Yeah.
Yeah.
Dr. Mark Gray, dermatologist, has agreed that it needs to come off. I think it needs to come off as a doctor, and you're the patient and you're happy for me to take it off.
Yes, of course I am.
For a number of reasons and logistics, we've decided that I'm going to do a house call and come here and take it out on your kitchen table.
That sounds good to me.
So the idea here is to remove this as kind of like an elliptical excision.
Yeah.
You make it the shape of like an eye shape.
Yeah.
Right? It needs to be maybe about 3 times as long as it is, or 4 times as long as it is wide. A 3mm margin, or even 5mm if you feel you can get away with it.
Yeah.
And I'd probably make it in kind of this direction here, which is the wound's going to be under the least amount of tension and kind of a vertical orientation there.
Or even a bit oblique with the way that,
Yeah, a little bit oblique.
Sure.
So you're going to want to remove that right down to the level of the fat.
Yeah.
Okay, because then you know you're going to get underneath it. You're going to have the whole of the roots, if you like, taken out.
Yeah.
And then you're going to end up with a defect, which is, you know, about that kind of shape and about that wide. And then you're going to need to bring it together with some stitches underneath the skin, and that takes a lot of the tension out of the wound.
Yeah.
So they're dissolving. They'll dissolve over many weeks.
Sure, absorbable sutures.
Yep. And then you're going to put a series of non-absorbable ones on the surface that you'll take out about a week or so down the track. Especially in remote areas, you definitely want to put ones on the surface of the skin, because you don't want a wound popping open.
No, it'd be a nightmare.
So we'll put some on the surface of the skin, which we'll plan to take out in about a week or so, and that way they won't leave any unsightly kind of stitch marks. All right.
Okay, well, we've done the surgery. We went out and got some powers, and we're just cooking up a bit of abalone, a bit of garlic, and it's a good way to finish the house call. You can come and stay here, you know, and do all this yourself. I don't know if they'll let you cut their leg or anything, but you come and stay at Book a Batch or Holiday Homes, and they've got a fantastic little sleep out there we've been in. So yeah, well, that kind of wraps up this part of the Dermalival adventure, and we'll get home and see what the histology shows. Thanks for talking me through the operation. And
all went well?
Yeah, well, I mean, you've seen the pictures, you're happy with the wound?
Yeah, I think you did a great job.
Oh, thanks.
Really good job. I have to employ you.
Yeah, that's it. Well, yeah, Dr. Tom Grubbs will work for the Skin Institute. Okay, well, I was a little bit worried that I wouldn't get it closed, so we got it closed. I was happy with that.
Yeah, the closure looked pretty good, Tom.
Oh, thanks.
Yeah.
So, happy with that. It's not infected, okay?
Yeah.
The next thing is we need to know whether I've got it all. So we've got the samples here. So that's the one off your leg.
You know, that's a pretty generous sample, so it looks like you've got a fairly adequate margin on that.
Well, I'll leave them with your staff and they can send it off to the lab, eh?
Yeah.
Excellent.
All right, Tom.
Cheers, buddy. Okay, well, I'm relieved. We've been on this whole jet ski mission. You've seen the footage. We've cut the lesion out. It turned out to be a basal cell carcinoma. We got the histology back where they look under the microscope. So the one on Susanna's knee was a basal cell carcinoma. The one on her chest was a squamous cell carcinoma. So on our trip we picked up 2 skin cancers. I went back, cut them both out. They were completely excised, so that means we got all the cancer. We don't need to go back and do any more. And to date, well, we actually closed the wound, so that was one of my worries. We knocked that one off. That never got infected, and we got all the nasty stuff, the skin cancers, and it hasn't split open. We're now 3 weeks post-surgery, and we talked to Susanna on the phone before. She's really happy. The wounds look good. She didn't have to come off the island. So absolutely stoked. It's been an absolutely fantastic mission. Had a lot of fun along the way, did some work along the way, patient's happy, it's all good. Thanks to the Skin Institute and everyone else that's been involved with this. It's been an amazing trip. So what's next for Dr. Tom on a mission? Well, we've been down south, so now I'm off up north to help my mate Lance O'Sullivan, New Zealander of the Year, GP, to do some work in Kaitaia. I've been to Kaitaia before, worked for 6 months at the hospital, so it's nice to be going back and maybe we'll get some waves in Ahipara.